Dr. Sirish Kumar. He's the second year DRNB resident in medical oncology from Master MIMS Calicut, and we have two eminent examiners today. Dr. Rona Joseph, Madam is Associate Professor in Medical Oncology from RCC Trivandrum, and Dr. Ashok. Ashok sir is a senior consultant in Aster Medicity. Sir will join us soon. He's traveling. So we will start today's session. Dr. Sirish, we can start.
Sirish, should just start presenting.
Yes, ma'am.
We'll be discussing it three headings, like the history, then examination findings, and then we'll discuss regarding the management aspects.
Okay, ma'am.
Okay, you can start presenting.
Okay. The history is patient is an 42-year-old lady residing at Calicut, is a homemaker by profession. Our presenting complaints were lump in the left breast for the past 5 months. Coming to the history of present illness, the patient was apparently well 5 months back, where she incidentally noticed a lump in the upper part of her left breast. The lump was of small size, which was insidious onset and progressive in nature, and has increased to present size involving the whole of the breast over 5 months. It was not associated with pain. There was no history of trauma to the breast. There is no history of redness or ulceration of the skin over the breast, or there is no history of any bleeding, no history of any lump in the axilla or in the other breast, no history of nipple discharge or ulceration, no history of any prior lumps in the breast, or prior history of surgery or radiation to the breast or chest wall, no history of chest pain, breathlessness or exertion or cough. There is no history of lower backache or other bone pains. There is no history of any headache, vomiting, or seizures. No history of significant weight loss or appetite loss. For this complaint, she was evaluated from another healthcare facility where she underwent a scanning followed by biopsy from the lesion, and she was referred to us for further management. Next, past history. No history of any surgery done in the past. No history of any previous malignancy in the past. She is not a known diabetic or hypertensive, and no history of asthma, no history of any cardiovascular disease or stroke. Personal history, diet is mixed, appetite is adequate, bowel and bladder habits are regular. There are no other habits. Coming to family history, there is no history of any breast cancer or ovarian cancers or pancreatic cancer in the family, or no history of any other cancers in the family. Menstrual and obstetric history, she is para to living to. Age at menarche is 14 years and age at marriage is 19 years. First childbirth at the age of 20 years. Second childbirth at the age of 22 years. There is no history of any hormone replacement therapy or oral contraceptive usage. She breastfed her both children for 2 years. Summarizing, on the basis of history, a 41-year-old premenopausal female with no significant comorbidities, no significant past or family history of malignancy, with an incidentally detected painless progressive left breast mass 5 months prior, which has progressed to present size involving the whole of the breast.
So, from the history, you have completed the history part. So, from the history, what are the important differential diagnoses will you consider in this patient?
Then first, there is a lump in the left breast, which was smaller size initially, which has progressed to the present size involving the whole of the breast. So, which has rapidly progressed over 4 to 5 months. So, I would like to think my first differential would be a carcinoma of the breast.
So, you described about the duration. What is the significance of the duration? You described about 5 months.
5 months.
And over the 5 months, it involved almost the entire breast.
Entire breast. So, it's rapidly progressing.
Yeah, yes.
Uh,
So, you mean to say it's an inflammatory carcinoma from the history?
Per se, there is no involvement of the skin as per the patient.
No, we are discussing the history now.
Yes,
so, how will you define what do you mean by inflammatory carcinoma? What are the criteria?
It's a clinical pathological entity, ma'am, where there is erythema or edema of the skin involving more than 1/3 of the breast mass, breast with or without underlying palpable mass. So,
Is there any cutoff for the duration of symptoms?
3 months, ma'am, less than 3 months usually.
And you mentioned about history of previous surgeries and all. So
Yes,
if you're suspecting a breast cancer, what is the significance of the history of previous breast surgeries or previous surgeries?
ma'am, on a personal history of breast cancer, ma'am.
Okay.
Then there is possibility of multiple biopsies, ma'am, whether a patient has any history of in the past.
Okay. Multiple biopsies.
Um,
Suppose after evaluation, this turned out to be a carcinoma breast. So what is the significance of this previous biopsies or previous breast surgeries with respect to management?
ma'am, history of previous biopsies are at higher risk, ma'am.
Yes, the risk is there. Yeah, of course.
More than
Other than
4%.
that,
Uh,
it can, yeah, is there any association with the imaging findings or the investigations?
ma'am, exposure to mammogram, ma'am.
Yeah. Other than that, previous biopsies can often cause difficulty in interpreting the mammogram, right?
Yes, ma'am.
Yeah, that is one thing. And another thing, it can affect the surgical management also. Breast conservation may be difficult. Even sentinel lymph node biopsies will be difficult in a patient who underwent multiple biopsies or previous breast surgeries. Okay. Hello?
Hello, ma'am.
Yeah. Then you described the next point is like the family history.
Yes, ma'am.
What is the significance of family history in a patient suspecting breast cancer?
Ma'am,
Why you want to elicit a family history?
ma'am, in the incidence of breast cancers in a family, it is around 10%, ma'am. So in that, around 90% of the patient will have BRCA1 or BRCA2 mutations, ma'am.
Pardon? In those patients with family history of breast cancer, 90% will have BRCA positivity.
The incidence of hereditary cancers is 10%, 5 to 10%, ma'am.
Okay.
So in that 10%, 90% would be around 80 to 90%
Oh.
BRCA1 or BRCA2 mutations, ma'am.
Okay.
So
Yeah. So there are different type of breast cancer based on the history. That's sporadic breast cancer, then familial breast cancer, and hereditary breast cancer, right?
yes, ma'am.
Yeah. What is the difference between hereditary breast cancer and familial breast cancer? Any idea about that?
Ma'am,
Are they the same, or is there any difference?
both are different, ma'am. The
Yeah.
family
Yes. What's the
history
difference?
might not have this mutations, ma'am. BRCA1, BRCA2 mutations or other mutations like CHEK2 mutations, PAL-B2 mutations or ET mutations, ma'am.
Yeah, that is in which one?
Family history, ma'am. Family history. Whereas
Familial
in
cancer.
familial cancers, whereas in hereditary cancers, there these mutations are seen, ma'am.
I think you are mistaken with that because hereditary breast cancer is associated with the hereditary germline mutations. Familial cancer, the cancers which run in families, it can be hereditary breast cancer, but there are other factors like the genetic, environmental, lifestyle factors also there. So all hereditary breast cancers, all familial breast cancers are not hereditary breast cancers. That is the point.
Okay.
So hereditary breast cancers are associated with the germline mutations. Okay.
Okay.
Yeah. Then what about the sporadic breast cancer? How will you define a sporadic breast cancer?
There are which
This is why you want to elicit the family history, right?
yes, ma'am. So without any family history or personal history of breast cancer in the families, other not only breast cancer, other cancers like pancreatic cancer, ovarian cancers, male breast cancers. Without
Yeah, no. I am asking about the definition of sporadic breast cancer.
these people will not have any hereditary mutations, ma'am. These mutations.
These are cancers which occur by chance,
Yes.
with no similar history of cancer in first or second or third degree relatives. They are known as the sporadic breast cancers. Okay. Then about the other history, like you described about the first childbirth, menarche, OCPUs.
Yes,
What is the significance of that in this patient?
ma'am, exposure to estrogen has a up to 2% risk of developing breast cancer, ma'am. So patients with nulliparous or early menarche and late menopause patients are at higher risk.
Because
Then
of the prolonged estrogen
prolonged
exposure.
estrogen exposure.
Okay.
Then first childbirth post 35 years are also at higher risk, and women with breastfeeding, not breastfeeding, will have more estrogen exposure. So they are also at higher risk of developing breast cancer.
Oh, okay, right. Okay, then I think you can continue with your examination findings.
Yes, ma'am. Coming to general physical examination, patient is conscious, cooperative, moderately built and nourished. Our ECOG PS is 0. Pulse rate is 90 beats per minute, normal volume and regular rhythm. BP is 120 by 60 millimeter of Hg in the right arm supine position. Respiratory rate is 18 breaths per minute. Temperature is afebrile. No pallor, ictus or pedal edema. No palpable cervical node. Coming to the local examination, first inspection. The inspection is done in the patient in the sitting position with arms by the side. A lump of approximately 7 to 6 centimeters is visible in the left breast. Left nipple areolar complex appears elevated, and left nipple appears retracted. On the skin on this surface of the breast, there is a pudy orange appearance is seen. No scars, sinuses, dilated veins, erythema, ulceration, or nipple discharge. Then asking the patient to raise the arms above the head, the left breast moves upwards with the nipple areolar complex elevated, and the inframammary crease appears normal. On asking the patient to bend forward, both breasts fall forwards in symmetrical fashion. Then coming to the palpation is done in supine position. Right breast at normal. On palpation of the left breast, there is no local rise of temperature, no tenderness. A single mass of size 18 to 7 centimeter is palpated in the left breast, almost involving all the quadrants with smooth surface, well-defined edges, and hardening consistency, and the skin or the swelling is cannot be pinched. Then coming to the examination of the axilla, a single hard, mobile, non-matted node of size 1 into 1 centimeter palpable in the left axilla. Then coming to examination of the both supraclavicular fossa and opposite axilla is normal. Coming to systemic examination, per abdomen soft, no palpable organomegaly, no ascites. Chest bilateral, normal vesicular sounds, no added sounds. Cardiac system S2, S1, S2 present. Central nervous system, higher mental functions are normal. No cranial nerve abnormal seen. Motor and sensory systems are normal, and no cerebral signs. Skull and spine, no tenderness. So on summarizing, a 41-year-old premenopausal female with no comorbidities, no significant past or family history of malignancy, with an instantly detected painless progressive left breast mass 5 months prior, which has progressed to present size involving old breast. On examination, a single mass of size 18 to 7 centimeter, palpable in left breast, hard in consistency, well-defined edges, and smooth surface, with single hard mobile left axillary node of size 1 into 1 centimeter. So my provisional diagnosis would be carcinoma left breast. Clinical staging would be CT4B N1 M0.
Just go back to your examination findings in the inspection. You examined the patient in different positions. Why you want to examine her in different position?
Ma'am, first to compare with the opposite breast, ma'am.
You ask her to bend forward and all.
Yes, ma'am. That to ask, I'm asking her to bend for her to know whether it is chest wall involvement is present or not, ma'am. If chest wall involvement
So
is there,
how?
breast would not fall freely, ma'am,
Mhm.
symmetrically with compared with the other breast, ma'am.
But you want to ask her to raise her hands.
Ma'am, want to look for the inframammary region, ma'am.
Okay. And palpation also, you palpated in different positions, right?
No, ma'am. Palpation is superimposition.
So, why don't you? I mean, is it essential to palpate in sitting up position or only in supine position?
Palpation would be done in
Sirish, yeah. Ideally, palpation also should be done in sitting up position and also in supine position. Otherwise, it will be difficult to palpate the axillary lymph nodes and all, right?
axilla, breast, I palpate in the supine position, ma'am. Axilla will be done in sitting posture, ma'am.
Okay. But breast palpation should also be done in sitting up position.
Okay.
So, by summarizing, your examination finding is CT4B N1.
N1.
So what is the composite stage?
Ma'am,
Composite stage?
it is stage 3B, ma'am.
Stage 3B.
3B.
So, you described about the pretty orange appearance and all.
Yes, ma'am.
What is the mechanism of the beauty orange appearance?
Ma'am, it is due to the obstruction of the dermal lymphatics, ma'am. Due to obstruction of dermal, that duct of the lymphatics will be taken in, ma'am, giving out a punch out appearance, ma'am. It look like an orange skin.
Looks like an orange peel. Yeah. So, apart from the beauty orange appearance, which are the other examination findings of a T4B lesion?
Ma'am, one is ulcerations, ma'am. Then satellite nodules.
So, ulceration, satellite nodules, and beauty orange constitute the T4.
Hi, Dr. Rana.
Hi, Ashok, you joined.
Sorry, I joined late. Yeah. Just one question. How much of the surface area of the breast is covered with beauty orange?
I mean, it is present over the around the nipple, sir.
Okay, so what percentage? Like, is it 25%, 50%, or is it just very localized and it's less than 25%?
It is around.
How will you say this is a T4D lesion?
Sir, beauty orange is in, sir.
Okay, but you have said this is a T4 B, right? B for boy.
Yes.
Yeah. So my question is, if you want to say this is a T4D or an inflammatory breast cancer.
Yes. No, not inflammatory breast cancer, sir.
Why is it not inflammatory breast cancer?
Sir, inflammatory breast cancer, there is erythema associated with erythema redness involving more than 1/3 of the breast.
Beauty orange? Yeah, more than 1/3. That is why I'm asking you how much of surface area of the breast is involved. Is it less than 1/3 or more than 1/3?
So less than 1/3.
So then, okay, fine. So that is what I want to know. And that should be mentioned somewhere in the case sheet because that makes a difference between T4B and T4D. And that also makes a difference in treatment also, right? Because if it's a T4B, you're going to give neoadjuvant chemotherapy. Yes. You can still proceed with the BCS for many cases.
Yes.
So for T4D, the chances are you're going to go for a mastectomy, right? You're not going to do a BCS. So it has real world implications on the treatment.
Yes.
So I think you should mention very clearly, if you say beauty orange, you have to say how much of beauty orange.
Yes.
Okay.
Okay.
Great. Go ahead.
Just before going to the investigation findings.
Yes, ma'am.
How are you going to manage this patient?
My primary aim would be to get a diagnosis and do the staging, ma'am, first initially.
So which are the diagnostic investigations you want to do in this patient?
Ma'am, first I would like to get a bilateral mammogram with USG correlation, followed by biopsy, ma'am. True cut biopsy.
Will you consider doing a bilateral mammogram in a T4B patient?
Yes, ma'am. Since our age is 41 years, ma'am.
What are the issues of doing a mammogram in a T4B lesion?
Ma'am, one is difficult to get this one, ma'am. Compress the lesion, ma'am, during the mammogram.
Difficult to compress.
Yes, so we may not get the exact delineation of the mass.
I don't know about that point. I'm not very sure about that. Okay, then mammogram, you'll do a mammogram.
Yes, ma'am.
So what are the examination, like you are expecting the findings in the mammogram you're expecting in that patient, T4B lesion?
And one is architectural distortion, ma'am. Asymmetry. Use mass, ma'am, first. Evident mass.
Okay. Just go to your next slide, your mammogram findings.
Ma'am, so right breast was there was no definite focal lesions, ma'am. And then there's a glandular prominence at 11 o'clock position is a Byrat's 2, ma'am. Whereas in left breast there is a large irregular high density lesion involving the mid third of the breast, involving all quadrants, with sono correlations shows irregular hypoechoic lesions extending from 7 to 5 o'clock position with relative sparing of 5 to 7 o'clock position. It's a Byrat's 5 lesion. With multiple.
What is this Byrat's? What is this Byrat's? What do you mean by Byrat's?
Breast imaging and radiological and
It's not radiological.
breast imaging.
Again, then what do you mean by this Byrat's 5?
Reporting, ma'am. Reporting and data system.
Okay. That's a breast imaging reporting and data system. So what is the significance of a Byrat's 5 lesion? What do you mean by Byrat's 5?
Ma'am, there is a it's highly suspicious of malignancy, ma'am, first. And then 95% risk. There is 95 more than 95% risk, ma'am. Likelihood of cancer.
More than 95% of likelihood of being a malignant lesion.
Being a malignant.
Yes. Then what about Byrat's 4?
Byrat's 4 is suspicious, highly suggestive of malignancy, ma'am. It's again divided into A, B, and C, ma'am. A is from 2 to 10% likelihood of malignant, and B is 10 to 50%, ma'am, and C is 50 to 95%.
Okay, right. So this is a Byrat's 5 lesion. So you after mammogram report, you identified a Byrat's 5 lesion. Then what is the next step?
When will you biopsy? At what step, Byrat stage will you biopsy?
Sir?
Will you send a patient with a Byrat's 3 lesion? Suppose this did not have beauty orange. This was a 3 centimeter mass and it is Byrat's 3. Would you send it for a biopsy?
Sir, your voice is not clear.
Sorry, I'm in a bit of a noisy place.
So
Yeah, Ashok is asking, when you ask for a biopsy, if it is a BIRATS 3 lesion,
no, sir. The routine screening is advised. Follow-up should be done after 6 months. So,
Can you hear me now?
yes, sir, I can hear you, sir. Sir,
Yeah.
I would not
So,
advise biopsy, sir. I would ask them to follow up after short interval, like 6 months, repeat mammogram.
okay. That is the general recommendation. But as a clinician, something that you should need to know is you should follow your instincts and your clinical acumen more than any radiological or any other test. Even if it is reported as a BIRATS 3, if you have a high clinical suspicion of a malignancy, if it is a hard mass, it is not mobile, you don't feel like it's a fibroadenoma, you are fully justified in sending for a biopsy. Okay.
Yes, sir.
Always, clinical acumen comes before any imaging or any lab test.
Yes.
If you think it requires a biopsy, you send. Now, this is something that once you are a consultant, once you are a practicing oncologist, you will have to do it yourself. You might be in a center on your own, and you are you have a high suspicion of malignancy. It came as BIRATS 3, but it doesn't matter. You have to send for a biopsy. So the correct answer to that is, if my clinical suspicion is high enough, even if it's a BIRATS 3, yes, I will send for a biopsy.
Okay, sir.
Okay.
Okay.
Right. What is BIRATS 6?
Sir, biopsy proven, sir. Biopsy proven.
Okay. Right. Okay. Go ahead.
yeah, after mammogram, what is the next investigation?
So I want to get a tissue biopsy for the diagnosis, ma'am. So I would like to get a true cut biopsy.
Why not an FNA?
Ma'am, FNSC, the yield may not be sufficient, ma'am. One, and IHC may not be possible on FNSC sample.
You can go for an FNA with cell block. In that case, you may be able to do the IHC also. The invasion, it may be difficult because in FNA, you cannot identify the invasion. So whether it is a DCIS or an invasive carcinoma. So that is why we needed cord-cut biopsy.
Yes.
So in that biopsy specimen, which
Biopsy showed invasive carcinoma grade 2. ISC was done. ISC was ER negative. HER2 was 2 plus with Ka 25 to 30%. And HER2 fish was done, which is positive.
So what do you mean by the grade? Grade of the tumor, this cancer.
Grading based upon
which is the
80
commonly used system?
Nottingham, ma'am.
Is it the original Nottingham or some
modification? Elston.
We usually use the
Bloom
modified
Richardson
Bloom Richardson.
modification.
Yeah.
Bloom Richardson modification.
Which are the 3 components of the scoring system, grading system?
Well, nuclear ATPR. Tubular formation and mitotic activity.
So based on these 3, this cancers will be grade 1, grade 2, grade 3.
Scoring is given based on that scoring. We grade the tumor.
Okay, so this is an hormone negative HER2 2 plus.
HER2 2 plus.
So what does that mean? HER2 2 plus.
Ma'am, it's equivocal, ma'am, on IHC. So we have to confirm with the.
Can you elaborate on the IHC finding of HER2 2 plus? What is HER2 1 plus, HER2 2 plus, and HER2 3 plus?
Ma'am, HER2 3 plus is complete membranous staining in more than 10% of cells, ma'am. Okay. And HER2 2 plus is weaker, moderate to complete staining in more than 10%. cells. HER2 1 plus is faintly or barely perceptible membranous staining more than 10%, ma'am, or it could be complete membranous staining less than 10%.
Less than 10%. So, will you consider doing fish in all cases, or
Oh, no, ma'am.
which are the indications for doing a HER2 fish?
HER2 2 plus equivocal is indication for HER2 fish, ma'am.
There are the two components of HER2 fish.
Well, there is a
It's a single probe or double
single
probe.
probe and a dual probe, ma'am.
Mm.
Single probe, we see the copy cells, ma'am. Whereas in dual probe, we check for HER2 and CEP17 ratio, ma'am.
So, which is the ideal one? Is a single probe or dual probe?
Ma'am, first we have to go with one testing. When one testing is we don't have results, then go for the other testing. So ideally, go for
Ideally, you have to do a dual probe. Average copy number and HER2 CEP17 ratio.
yes, ma'am.
Yes. Okay, so finally, this came as HER2 positive, hormone negative, grade 2 breast cancer.
Great questions.
So now we have got a biopsy room. Then what will you do now?
And next I would go for staging, ma'am. For staging, I would get an PET CT.
Okay. So you got the PET CT image with you, or?
Report only I got.
Yeah, yes.
So there is a large primary malignant mass lesion that is around 8.2 into 6.3 centimeter in left breast with axillary lymph node regional metastasis. No? There is no definitive evidence of any other lesions.
So the skin involvement is not mentioned in the PET scan.
No, ma'am.
So what is your final diagnosis, final stage?
Final stage, again, I would keep it as same, ma'am. CT4B and 1, ma'am.
Yes, yeah, this is a combined staging, clinical and radiological. So there is clinical evidence of skin involvement.
Yes,
So it is a T4B N1 M0.
yes, ma'am.
Okay, how will you proceed in this patient? I mean, what's the next management?
Since patient is in HER2 positive and it's a T4 lesion, since it is stage 3B, I would like to consider neoadjuvant chemotherapy followed by surgery.
Just a quick question. Can you define HER2 ultra low disease?
So that is ultra low is
it is something you will have to learn because such a concept did not even exist when we were PGs.
yes.
So it has come up only in last 1 year. So it is something that you will have to live with. So I think you should know it.
So
Okay.
HER2,
HER2?
that is with less than 10% of cells showing this complete membrane staining, sir.
Complete? No, it's
Yes.
incomplete.
Yes.
That is ultra low. An incomplete membrane staining, less than 10% of cells showing incomplete membrane staining is HER2 ultra low. Okay.
Yes.
When more and more drugs, antibody drug conjugates come, this will be an important section of your treatment protocol. More than 50% of your patients, breast cancer patients, will
Yes.
fall into HER2 ultra low.
Yes.
So it's something that you'll have to keep in mind. Yeah. So go ahead with your neoadjuvant. What you would like to do.
So since it is T4 with N1 lesion, I would plan neoadjuvant chemotherapy with taxane-based chemotherapy with preferable dual anti-HER2 antibodies, sir.
So from which all stage onwards will you consider giving neoadjuvant chemotherapy in HER2 positive breast cancer? Or what are the indications for giving NICT in HER2 positive breast cancer?
NICT indications are any node positive disease, N2,
N2.
matted N2 or N3 lesions, and CT4 lesions.
We are discussing about
Uh,
HER2.
Boss, you don't have to say N2. Any node positive means N1, N2, N3, all of that is node positive, you know.
Yes. So any
So if you're going to give for N1, you'll definitely give for N2.
yes.
What madam is trying to ask is your lower limit of your cutoff for starting
T2
HER2 block.
more than 2 centimeter.
Okay. T2. So you're saying if it is
N1
T2, you're sure of that?
more than 1.5 centimeters actually.
Will it? If I ask one more time, will it come down to 1?
No, sir.
Okay. So your final answer is 1.5.
T1C, sir, actually. T1C. Sir.
Okay. So you'll start the patient with 12 anti-HER2
Yes.
plus taxanes.
Taxane-based chemotherapy.
So will you give trastuzumab, pertuzumab, and paclitaxel?
My chemotherapy plan would be docetaxel with carboplatin plus dual R2 antibodies.
TCHP.
TCHP.
So anyway, this is your DM exam. So what is the reference or why you want to give TCHP in this patient? The evidence for giving TCHP.
In the trials, we showed TCHP as produced a pathological complete response of around 60 to 70%.
Which trial
Yeah,
is that?
which trials?
TCHP is trained 2 trial. Then there is Trifena trial.
In train 2, they have used TCHP.
Yes. Then this Trifena trial.
Yeah, that is based on the Neosphere and the Trifena trial.
Yes.
They were the landmark trials, which lead to the recommendation of dual anti-HER2 plus chemotherapy. That's a TCHP regimen as a standard of care in HER2 positive early breast cancer. We are planning an neoadjuvant treatment. Okay, so
Yes.
how will you give TCHP? What is the dose of
Yeah, write a
different
prescription
agents?
of TCHP.
Sir, first docetaxel would be 75 mg per meter square to be mixed in 250 ml NS and infused over 1 hour. Then carboplatin, AAC 6, we are using AAC 5 or 6, sir. It has to be mixed in 500 ml D5 to be given over 60 minutes, sir. Then trastuzumab, first cycle, it would be 8 mg per kg to be mixed in 250 ml NS and given over 90 minutes during first cycle, and subsequent cycles we can come down to 60 cycles, and the dose should be 6 mg per kg for subsequent cycles. And pertuzumab, initially it is 840 mg in 250 ml NS over 1 hour, and subsequent cycles it is 420 mg, and it's 420 mg subsequent cycles.
So, which agent will you give? Docetaxel or the anti-HER2?
My first R2 agents to be given, followed by docetaxel, then carboplatin.
So, are we still using the IV regimens, or do you have any other alternative options?
And there is subcutaneous route for anti-R2 antibodies, that is FESGO, which can be given as subcutaneous. It is dose is 1200 mg by 600 mg for first cycle, followed by 600 mg or 600 mg for subsequent cycles.
Okay. So, before giving this anti-HER2 molecules, especially trastuzumab,
Yes.
what are the prerequisites you need? Or what are the most complications you are expecting in a patient's
Then
in
for
a patient?
trastuzumab, for per se trastuzumab, I would like to get a baseline echo scanning.
Okay.
And to be repeated every 3 months, ma'am.
So after echo, you'll give trastuzumab to all patients, or is there any cutoff for not giving
EF
trastuzumab?
should be more than 55%, ma'am. In
55 or is it 55?
is less than 60 years. I think it's more than 55%, ma'am. And I'm not sure about that percentage.
Yeah, you read about all the. It's very important. It is more than 50. That is the usual recommendation. So then when will you repeat the echo? How frequently you will do that cardiology evaluation?
That is said once in 3 months.
Once in 3 months.
So after 3 months, the patient comes and you do an echo.
Yes, sir.
The baseline echo was 60%. Now it is 50%. What will you do?
So when there is EF reduction of more than 10 to 15%, we have to stop the chemo, then repeat the echo after 4 weeks. Then
Stop the chemo, stop the trastuzumab. You don't have to stop the chemo.
stop the trastuzumab for 4 weeks, then repeat echo. If EF is improved, then we can restart the trastuzumab.
Wrong. You should read this once more. So the absolute fall of more than 50%, provided that the value falls below 50%. More than 10%, provided the value falls below 50%. This is what I remember. So basically what I'm saying is, if you have an EF of 75% and next time the patient comes to you with 60 or 65, you can still give it.
Okay.
So the absolute fall, provided that absolute fall of more than 10 to 15% takes it to a value of less than 50%,
Okay.
is when you hold. Now, I think this is what the Tricina trial had said.
Yes.
So you need to know when to stop. You can't keep doing echo every 3 months, and you should know how to act on that.
Yes.
So when you get a value, you should know how to act on that. So that is something that you have to follow. And the cutoff is 50%. Only one trial involving trastuzumab had a cutoff of 60%. That was a metastatic trial. Other than that, almost all trials, the cutoff was 50%.
Okay.
And does adding trastuzumab change anything? The cutoffs, I mean.
No, sir.
Okay, doesn't change. Right. So go ahead. You're going to give TCHD for 6 cycles.
6 cycles. Then go for surgery. And then look for histopathology report. Look for PCR, sir.
Okay. So
then if
patient has PCR.
Sir?
What will you do? Patient has PCR.
Sir, then continue pertuzumab and trastuzumab up to 1 year, sir.
Why do you want to continue both? Why can't you give only trastuzumab? Is that what you do in your center? Do you give trastuzumab and pertuzumab?
Only trastuzumab.
Only trastuzumab. So then why did you want to give both? You're right actually, but you have to tell me why. If the patient can afford, in this patient, yes, you are justified in giving both. But why?
So what is the evidence for giving adjuvant dual anti-HER2? That is what Dr. Ashok is asking.
So node positive, there is 2% increase in DFS when pertuzumab added. Okay.
So basically, you give it for high risk patients. Now here, it's basically a mix of evidence and your clinical experience. So there is a clear cut reason why you should give dual HER2 because it is at presentation node positive disease. And its second thing is it's a large tumor. Tumor size also has a bearing on outcomes, on overall survival, on outcome in general. And the third thing is, this is a young patient. I think it's 40 years, no?
Yes.
So any young patient, you tend to be a little more aggressive than you usually are with other patients.
Yes.
So these are all reasons why you can offer, say that yes, these are the reasons why I'm going to give dual HER2.
Yes.
Okay, so everything you do has to have an explanation. Now, dual HER2, you may end up giving only single HER2 because of many other reasons, because the patient can't afford. Or, mostly it's going to be because of logistics and the patient can't afford and so on and so forth. But the fact is, this is the reason why you will give,
Yes.
why we will offer it to be given. Okay,
Yes.
right. Go ahead.
It's just one more point. Like in our practice, we know majority of our patients may not be able to afford this dual anti-HER2 neoadjuvant chemotherapy. So what are the other options available?
Ma'am, as a
Sirish?
neoadjuvant, ma'am, or you're asking about
In the neo, I'm asking about the neoadjuvant.
neoadjuvant? Then both not affordable for both anti-HER2 antibodies, ma'am.
Pardon?
Question is about patient not affordable for both anti-HER2 antibodies, ma'am.
Yes. Patient cannot afford dual anti-HER2.
Then I would like to add adriamycin, ma'am. Adriamycin based chemotherapy followed by 4 cycles of adriamycin cyclophosphamide followed by 4 cycles of taxanes plus carboplatin.
Okay. That is the ACTH regimen.
Yes, ma'am.
But we can very well use the TCH.
TCH.
So
Yes.
you want to add anthracyclines? We know about the cardiotoxic effect of anthracyclines. Do we need to add anthracycline or can we use TCH?
TCH is better PCR compared to the ACTH, ma'am. So
TCH? TCH?
TCH is,
Can you just repeat that?
TCH is better PCR compared to the ACTH, ma'am.
That is for TCHP, right? Not TCH. So in a patient who cannot afford dual anti-HER2, which neoadjuvant regimen will you consider? That is what I'm asking.
TCH, ma'am.
TCH. So you're not using anthracyclines.
Yes, ma'am.
So both these are options of neoadjuvant treatment. But in young patient and with high disease volume, it is better to add anthracyclines because anthracyclines has got a definite edge in HER2 positive breast cancer, definite benefit. So we use sequential anthracycline taxane plus trastuzumab. That is another option of neoadjuvant treatment.
Yes.
Okay. So after the primary surgery, there was PCR and you started patient on dual anti-HER2.
Yes.
So what will you do if there is no PCR?
And then change to trastuzumab emtansine.
Trastuzumab emtansine.
Yes.
What is trastuzumab emtansine?
It's an antibody drug conjugate, ma'am.
Yes. So what is the payload? What type of linker is it using? Or what is the antibody?
Linker, ma'am. Linker is thioether and payload is emtansine, ma'am. It is
emtansine. What type of molecule is emtansine? Say microtubule inhibitor.
Microtubule
right?
inhibitor.
Yes.
One.
And it has what a non-cleavable linker. So what is the evidence for giving TDM1 in a patient who didn't achieve PCR after NACT? What is the evidence?
Catherine trial.
What is the benefit?
There is recurrence risk reduction of up to 50% and DFS is improved from 75 to 85 to 85%, is around 85%.
I think you have to read about all these landmark trials, the Catherine trial and all. Okay, just read about the benefit. So, which are the common complications we expect in a patient who is on TDM1?
It's peripheral neuropathy, ma'am. Hepatic transaminitis, ma'am. Then
Most common complication?
thrombocytopenia.
Yes, there's a thrombocytopenia. Patient can develop transaminitis, and some patients, the peripheral neuropathy is also reported because of the payload. How many cycles will you give?
13 cycles.
How many?
Up to 1 year, 13.
Yeah. In the Catherine trial, they had went for 14 cycles. So, 14. Okay.
So everyone who is watching this, try to answer after the candidate at least attempts, so that not too many. I was just looking at the chat websites. Everybody's answering in that. So allow the candidate to answer, and if you can't get it, please be free to help him. Yeah, go ahead. Please continue.
So, this patient, she's a locular advanced breast cancer. How will you follow up her, that patient? She completed 1 year of anti-HER2 treatment and is on follow-up.
Every up to 3 years, every third monthly clinical examination, ma'am. Then
only clinical examination is required.
ma'am, then
No other
annual
investigation.
is the chest X-ray and USG, ma'am. 6 monthly and mammogram annual.
Why you want to do a chest X-ray and ultrasound in a breast cancer patient? What are you going to what findings you are expecting in that patient by doing a chest X-ray and ultrasound? What is the recommendation?
Recommendation is third monthly clinical examination, ma'am. Up to 3 years
Yes.
and annual mammogram.
Okay.
3 years.
Anything else? Chest X-ray and ultrasound is they're not recommended. So anything else, like she received anti-HER2 treatment.
Echo, ma'am.
What is the frequency?
6 monthly, ma'am.
6 monthly for how long?
2 years.
Up to 2 years, it is mandatory to do, and after that, that is based on patient symptoms, and you can consider doing echo. So annual mammogram is the recommendation. Yes. So suppose this patient developed metastatic recurrence maybe after 1.5 years of treatment. She presented with breathlessness. Sirish?
Ma'am, I would like to
yeah.
One is to get breathlessness. First, rule out the cause, ma'am. What's the cause for that one? First, whether it's a pleural effusion or any cardiac issues, due to cardiac issues, or whether it is due to lung involvement, ma'am, lung metastasis.
You will do a metastatic workup.
For metastatic workup, ma'am. So,
what will you do?
One is we can get based on symptoms. We can get in CCT thorax, sir.
I mean, keep it simple. You did a X-ray, and she has a massive pleural effusion. What is the next test you will do?
Then first to patient should be relieved of the breathlessness. So I'd like to do therapeutic synthesis.
Okay.
Then followed by
positive. Next, what you will do?
So then I would get in cell cytology and cell blocks, sir.
That I told you, it's positive. What do you want to do? Any imaging?
I will get in a PET CT, sir, to look for any other sites.
Okay, only PET.
So R2 positive.
Yeah. So
Asymptomatic MRI brain, if it's only symptomatic, we can do, sir.
if it is asymptomatic, you need not do. But personally in my clinical practice, if it's a HER2 positive, especially an early relapse, I usually do MRI. Okay, so if it's not in the guidelines, so in an exam situation, what you should answer is, as the patient is asymptomatic, or I have not been given any idea, any clue that the patient has CNS symptoms, I will not do an MRI brain.
Yes.
You can say like that.
Yes.
Okay, but in clinical practice, I'm just telling you that most of us will probably do, especially if it's an early recurrence.
Yes.
Okay, and now you do an MRI brain. Suppose you do an MRI brain and it's positive.
Yes.
What is the drug of choice in your opinion
So,
for the next line of therapy?
my next line of therapy would be trastuzumab deruxtecan.
Okay. I think you're a bit shaky about the trials, so I'm not going to ask you that. But please do read about all the Destiny Breast trials. They are all very important.
Yes.
You can go ahead.
Yeah. So we have got a lot of options. Like today's discussion is mainly about the locally advanced breast cancer. So this is a metastatic recurrence. What do you mean by this trastuzumab-free interval? What is the significance of the trastuzumab-free interval in a patient's?
Patient was previously treated with neoadjuvant trastuzumab pertuzumab with the disease-free interval of up to 6 to 12 months.
6 to 12 months is a wide gap, right? 6 months or 12 months? If it is, suppose it is 8 months, then what do you do? Right now you told us that you will be using TDXT.
Yes.
So what is the significance of the trastuzumab-free interval?
Whether to use the trastuzumab deruxtecan. If it is more than less than 12 months, we can use the trastuzumab deruxtecan.
It's more than 12 months, will you use the dual anti-HER2? Okay. In this era of TDXT, I don't think that trastuzumab-free interval is not a very important parameter. Previously, because of the limited anti-HER2 molecules, we used to decide about for the like metastatic management based on the TFI. It is more than 1 year, then often we try using the same agent once again. But now with the availability of a more potent agents, there is not much significance. So, Ashok, can we just conclude with that today's presentation, or do we need to discuss the metastatic?
Hi. Yeah, I think we can wrap it up. I just want to ask you one more thing. Will you do any high penetrance genetic analysis for this patient?
Yes, sir. I would like to do some genetic testing since patient is. I would like to do, sir.
Okay. Why?
Is HER2 positive, sir? Age is less
That's
than
not a reason. Yeah. Age is
less than 50 years.
less than 50. Okay. So again, please read the NCCN guidelines. Its cutoffs are 45 to 60, and above 60, like that. So any patient under the age of 60 with triple negative, any patient, whatever it is, whatever type of breast cancer under the age of 45, from between 45 to 60, there is a number of criteria that you have to follow.
Yes.
NCCN guidelines for BRCA testing, please follow. So that's it from my side. Otherwise we can wrap it up.
Yeah, Sirish, your examination findings, history and examinations were all okay, but I think you have to be more strong about your discussion part, the management, the studies, trials, evidences, and all.
Yes.
Read about all those things.
Yes.
Okay.
Yes.
Yeah, Munir, you can close the session, Munir. Munir, are you there?
Okay.